The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're very fortunate again this month to be talking to Dr. Pat Cartwright from Department of Urology at Primary Children's. Welcome back, Pat.
Hey, Paul. Thank you.
This week, we want to talk a little bit about management of hydronephrosis. And I think that this has been something that has, I think, gotten more systematized over the last few years, and I think that's been helpful. Is that your perspective?
I think that's true.
Well, let's dive right in. So have you developed any disclosures in the past week?
No disclosures.
All right. 5 years ago, when we started this nonsense, we talked to Jeff Prince about a more systematic approach to grading prenatal hydronephrosis with the aim, I think, for the person who's meeting that baby in the nursery to have a much better plan for how to engage then both the diagnostic process and engage you folks. Did you get the sense that in the past 5 years that system has become more used and useful?
I think the data would say it has. It's probably used in 60 to 70% of pediatric hospitals. That's the UDT classification system, which is urinary tract dilation. And essentially they picked UTD so that all the other confusing and fuzzy terms aren't utilized, like pyelectasis and pilocaliectasis and all those things where you scratch your head about how they're different. So they just use urinary tract dilation. And they have both an A and P category, so antenatal and postnatal. And then within each of those, they have level 1, 2, and 3, which is mild, moderate, and severe. And those are risk categories. So a 1 would be low risk, 2 moderate, and a 3 higher risk. That sort of got put together by a consensus group, which involved primary care, radiology, nephrology, urology. And I think it's a nice system for general use in terms of somebody looking at a report and saying, if it's a level 1, it's a really low risk patient. And overall, those don't require immediate referral. 2s and 3s are higher risk and probably do need early pediatric urology or whatever appropriate consultation. I would say peds urologists don't, it's not that we don't like that system, but it's not really designed for us in terms of surgical decision-making and such. That's a little more of a general system to assess risk that anyone can look at and say, it's a 3, I better get consultation at this point. So it's useful that way, I think, Paul, for sure.
I do find it extraordinarily useful for someone like myself that, that at least I can look at a recommendation for what I ought to do with that patient. Do you think that me using that ends up working well for you folks?
Yeah, I do. And I think that is its big benefit. I think if you see a patient who had an antenatal diagnosis of hydro, which is pretty common, right? Like 1 to 0.8 to 1 out of 100. So see lots of these. Mm-hmm. If they have a P1, so their postnatal ultrasound is by the radiologist determined to be low risk, I don't think those kids need urology referral. I think that's one that can be followed up with a subsequent ultrasound, probably at 4 to 6 months of age, with no other sort of consideration for VCUG, prophylaxis, anything like that. It's really low risk of future issues. So Anthony Schaefer, my partner, actually has an NIH grant looking at antenatal hydronephrosis into the postnatal realm, and a lot of the specifics that may allow us to give more value-based care, like where are we wasting money on re-imaging and things like that. So more to come from Anthony in the future on some of this.
We'll keep our ears to the ground. So in doing the postnatal evaluation, most of the time it's recommended that we wait at least 48 hours. What's the reason for that?
It's basically the relative oliguria of a newborn. A lot of shift in renal blood flow around the time of birth, and often urine output's really low for the first 1 to 2 days. And it's essentially like an unhydrated pneumonia. that doesn't show up very well until fluid's on board. When you're not making much urine, you underestimate the degree of hydronephrosis in terms of what really plays out in the long run. So that's the main reason for the delay.
And so in the higher risk categories, we do that with the understanding that we're still getting a slightly skewed view.
Yeah, I think that's right. When they're severe, and especially if they're bilateral, you just sort of move forward early after birth, because sometimes they may need a catheter placed or other things that we'd like to know about sooner. And we just take into account that they're relatively oliguric. But the more severe ones, I think, tend to have less variability based on that newborn age issue. So if they're more severe, just move forward as soon as possible after birth.
And in broad terms, what are the things that increase the level of risk?
So the UTD looks at basically 6 different things, and it's the things you might expect. It's like AP diameter of the renal pelvis. Is there a dilated ureter? Is the bladder wall thick or abnormal? What does the renal parenchyma look like? So the more severe the hydro, the more thin the parenchyma, the more abnormal the appearance of parenchyma. All those things increase risk of both renal insufficiency, often UTI risk, and certainly it portends the need for intervention the worse all of those things get.
It's interesting because parents will sometimes ask, well, why do things look different after a child's born than before? And my response to that is usually, how in the world do we see anything going through as many layers as we do in a prenatal ultrasound? So we have a baby who arrives with a risk category, and certainly one of the possibilities is after the baby's born that the ultrasound is completely normal, and at that point we got nothing to do. And
Yeah.
you would also argue that if it's a P1 designation, that we can probably manage that.
Yeah, I think that's right, Paul. So if you have an A1, so an in utero mild abnormality that resolves before the end of pregnancy, which is fairly common, you may not even hear about those often. I mean, maybe up to 50% fit that category, 40, 50%. Most of the data says you don't need to do a postnatal ultrasound if it's resolved in utero and was fairly mild to begin with. If you have a child that had antenatal hydro that never resolved in the antenatal period, but is gone or greatly reduced and on the first postnatal ultrasound, those patients probably do warrant one more ultrasound at 4 to 6 months, as sometimes you'll see it worsen. And I would say that's a group that's perfectly appropriate for pediatricians to manage and not refer to us. So an antenatal that looks normal on the first postnatal ultrasound, get one more image when they're older. And if that looks good, no further follow-up needed.
And just to reiterate, for that group of babies, obviously we don't want to do that ultrasound in the first 48 hours. When would it be optimal to get that first postnatal ultrasound?
Yeah, I would say for most people in practicality, it's 5 to 7 days of age. Lets them get home, kind of get their family life together. It's not a real rush. The kid will have increased the urine output by then. They're probably more comfortable taking the kid out. So I usually tell them shoot for around a week after birth.
And so in terms of the way we plan things, that after baby's had its newborn exam in the office, that's an ideal time for us to set something up.
I think that's right. And I just make sure I'm saying the right thing in terms of the timing. I sort of like a week also because I've always thought that the baby's going to see you guys at 2 weeks of age generally. Is that
We see the
accurate,
baby.
Paul?
We see the baby usually for a newborn visit after the hospital, and then 2 weeks.
Okay. So after the hospital, like in the first couple of days, they come in for
Yeah,
bilirubin assessments and basic stuff like that. Got it.
you're
And
feeding.
then,
Yeah.
and I think I've always thought if I get it at a week, then the pediatrician will have it at the 2 week visit and can review it and make sense of it at that point. So in practicality, that's where I think it fits most easily.
Win-win. Let's say that a baby goes beyond P1, and so we're going to call that moderate P2 or P3. What factors make that a P2 or P3? And how's that different from, is it just the timing, or are things different than they are in the A2 or A3 studies?
The criteria that are examined and compared are the same for
Okay.
antenatal and postnatal. Certainly, we get a lot more detail, as you sort of alluded to previously, once they're delivered and we can see things directly. So things that would worry us. So dilated ureters worry us in 2 ways. It increases the risk there could be a bladder outlet obstruction, in a boy, a valve or something like that, which needs immediate intervention. And any child with a dilated ureter, in addition to having hydronephrosis, is at an elevated UTI risk. So even if it's a UVJ obstruction or a megaureter without any bladder outlet obstruction, they probably have a 4 or 5-fold higher UTI risk than a UPJ obstruction. And it's probably because kids get intermittent bacteria normally, right? So bacteria up the urethra and the bladder. And if they have a dilated ureter sitting right there next to it, the chance of bacteria getting in that static, poorly draining ureter is higher than making it all the way up to the renal pelvis. And so if they have a dilated ureter, we think about prophylaxis early on, or at least have that discussion with the family. And certainly if they have hydronephrosis and a dilated ureter, reflux could be in the picture as well, and their infection risks go up with that. So that's one way we would sort of sort through things and change our management based on what we see with ureter. I mean, I think the other overall important thing for pediatricians to be aware of, and I think you are to some degree, is that we generally don't see dramatic function changes, even from ongoing moderate or even sometimes fairly severe appearing obstruction. Those kidneys don't go bad quickly because of hydronephrosis. Posterior urethral valves are a little bit of a different circumstance where there's super high pressures involved. But from UPJ and UVJ, a lot of those we can watch for a few months or even 6 or 12 months for growth and development. And when you sequentially look at, their overall GFR, it stays good. And the relative function of that kidney on the scan stays good. So we kind of have a window to watch with growth and see if some of these can improve over time. And sort of the two most common things are UPJ and UVJ obstruction, which are in most cases a small underdevelopment segment of the ureter, essentially. So when you look at it, it doesn't have normal muscle development in it, and it's small in caliber. Essentially, you have a little increased pressure above that and dilated system. And the real question is whether those small segments are normal enough in terms of histology and physiology to respond to growth signals over time, get bigger, create more of a luminal diameter, and improve over time. That's kind of what we're waiting on, is to see how normal that segment is and whether it can grow with the kid, and you'll see less hydronephrosis over time. So we're generally waiting in most circumstances is the route we'll take. 90% plus of the time, there's nothing we need to do immediately.
What proportion of the kids that you see are going to get more studies than ultrasound?
So the things that would be an indication early on for a VCG is hydronephrosis of grade 3 or above. So a 3 or 4 on the SFU grading scale, which would be a P3 on the UTD scale. So a higher risk patient, or a ureter that's dilated bigger than a centimeter on the ultrasound. So they're going to get a VCG for sure, since they're at higher risk for UTI and reflux, and we'd rather know about that and choose management strategies based on that. The other thing is if they have parenchymal thinning, so more severe grades of hydronephrosis, they'll often end up with an early renal scan to see what the relative function of that side is and to see the drainage time, which gives us a good estimate of severity of obstruction. It's also, even if the vast majority of those we're not going to intervene in earlier, so it's pretty rare that I'll operate on a 1-month-old with hydronephrosis. Sometimes it's really severe or bilateral, and we think that's the best course. If we can get the renal scan early and know that the affected kidney functions at 48% of the total, right? So 52 on the normal side, 48 on the affected side. If we're watching over time and the hydronephrosis doesn't get better and we repeat a renal scan and now we're down to 42% or 40%, the initial scan is a really good baseline for us to make decisions on later. Like, we're losing ground with this kidney. The other thing about that is that when we wait, if we see a diminution in function over time, but we followed up at 3 to 4 month intervals, almost always that diminution is reversible with pyeloplasty. So the one that's dropped from 48 to 40 almost always bounces back to its original state if we've followed up in a fairly consistent fashion. So that's why it's sort of safe overall, watching for infection risk, especially in the dilated ureters. But otherwise, we see a number improve. And even if we lose in the long run in terms of not seeing improvement, surgery at that point has a good chance of taking us back to where we started.
How do you make a decision about prophylactic antibiotics?
A lot of debate and controversy about that. So probably any kid with grade 3 hydro, is my opinion and my approach, grade 3 hydro or above and a dilated ureter, even without reflux, so it's like a UVJ obstruction, deserves prophylaxis for the first 3 to 6 months as a minimum. just based on the fact that any UTI is a much bigger issue in that age group, with potential progression to sepsis being a higher percentage, harder to diagnose, more renal damage from any pyelo episode that occurs because of sort of fragile, tender growing kidneys. So the first 3 to 6 months of life for sure in that group. Same thing with kids who have reflux diagnosed, at least 6 months of prophylaxis. In the higher grade reflux, people would say even to a year. And at that point, a trial off prophylaxis is a reasonable thing. So kids with known high-grade reflux, hydronephrosis with a dilated ureter, 3 to 6 months of prophylaxis, and then individual decision-making. And a lot of that, in honesty, is parent-based, right?
Sure.
How comfortable they are with it. And we talk about pros and cons. And I've become progressively more comfortable over time with taking kids in the 6 to 12-month range off if we have really attentive parents and they understand risk and will get seen and diagnosed quickly and not, sit at home and come in to see you 7 days later with a super sick kid. Most of the data would say with pyelonephritis, if you can diagnose and treat it within 24 hours of fever onset, you greatly reduce the chance of a new renal scar. So in that circumstance, I'm pretty comfortable kind of working with the family on just being compulsive and getting seen if there's a fever without an obvious explanation.
Yeah, and clearly that we're part of the equation, that we recognize there's been a change there. Do you ever recommend circumcision as part of medical management of?
I would probably say proactively, no.
Uh-huh.
If people ask me, I do think that UTI risk is higher, right, in any uncircumcised kid, even with normal urinary tract anatomy for the first 6 to 12 months of life. That's a for sure thing.
Right.
If you have abnormal urinary tract anatomy, it goes up higher. If it's something like a UPJ obstruction, there's so little increase in the UTI risk that it's a baseline consideration for circumcision. Nothing that really pushes you to do it. I would say in kids with high-grade reflux and more complicated urinary tracts, it's a relative indication for considering circumcision. So if they ask me, I do tell them that I think there's probably a potential benefit in reduction of long-term UTI risk in their child being circumcised, but it's not super strong and certainly not a standard recommendation.
Really, yeah, something where you'd see that as the standard of care.
Yep.
Yeah. Anything else you want to say about that? I wanted to ask about older kids too.
I think we got it on the younger kids.
Okay, so which kids need a workup for possible reflux that wasn't noted prenatally? When do I wonder with a UTI?
Yeah, got it. So I think the AAP guideline, which they reaffirmed in a recent reassessment, has turned out to be pretty good overall. And that was basically for kids 2 to 24 months of age. If they have a single febrile UTI, ultrasound only, if that ultrasound finds abnormal findings, which include dilated ureter, thickened or abnormal bladder, renal scarring, hydronephrosis above a grade 2, those deserve a VCG just with the first UTI. I think that's reasonable. If those things aren't present on the ultrasound, it's pretty normal looking kidneys and just one febrile UTI, waiting for a second febrile UTI is a reasonable approach and what I've generally done. I would say that one thing to throw in there, which wasn't in the AAP guidelines, is if there's a family history of reflux. It's a pretty strong familial component to reflux, right? If one SIB refluxes, the other kids, if you test all of them under age 5, about a third will have reflux. So if they have a refluxing SIB and had a febrile UTI, I think that's a separate discussion with the family. Like, there's a risk of reflux here. Do you want to get a VCG now and know that, or are we going to wait and see if there's a second UTI? I think you can argue easily for both, but I think family history of reflux is one thing to consider in there.
What about the older child? What about a child who's older than 2 with febrile UTI?
Yeah, I think even though the guideline says, I meant to mention that 2 to 24 months, I apply it to the older kids as well. It's not data-based the way the 2 to 24 is, but I think that 2 to 24 is those are the highest risk kids. And if you can do well with that approach with them, that you can do well with the older kids. So I think those same guidelines are pretty much applied to older kids.
Do you think there's been a shift over the course of your career in how we approach imaging? It seems like we did a lot more VCUG in the past to me.
Oh, a ton. I think that's right. We've way gone down on VCG, and probably appropriately so in most cases. It used to be any kid with a first UTI got ultrasound and VCG. It was simple, and there's some beauty to that, but I think we way overdid it. And I think that sort of got recognized over time. The other
Much
issue
more
is,
invasive procedure.
say that again, Paul,
A
sorry.
much more invasive procedure.
It is for sure. We're still looking for a catheterless way to, they actually have something, but it involves an IV. It's a sonicated molecule that you give IV, and then you apply some energy. It's ultrasound focused energy over the bladder, and it creates bubbles or sonicates the
Wow.
CO2. And then you can see the CO2 in the bladder, just like they used to do for heart studies, right? Where you could see the air bubbles. And it's pretty cool, but it still has an IV involved. So we need an oral one that we can do that way. But
or aromatherapy.
maybe along with it, you get aromatherapy. Doesn't that make everything better?
Yeah, I'm smelling sandalwood, and now I know what's going on.
Who doesn't love a good smelling garden?
Oh my! It's July right now, and my lavender is beautiful. All right, Pat. Anything else we ought to be thinking about?
I think that's it. I would say that probably in summary, pediatricians should feel comfortable with the P1s and following up on their own. And if it persists at 6 months, send them to us, and we're happy to take a look with you. Most hydronephrosis doesn't need urgent draining or surgical management. A number of them will get better over time. And prophylaxis, trials off prophylaxis at earlier ages is probably something we've trended towards without much evidence of that having a negative impact. And parents really like getting off the antibiotics. So you'll probably see more of that from us and have to discuss it with families yourselves a little bit. So yeah, thank you.
Which is a great intelligent thing to be able to do, to talk to our families about what we're doing. Yeah. Well, terrific. Thanks so much, Pat. For those of you who have questions, please send your questions to questions@vcurb.com. We'll talk about those in a couple of weeks, and we'll talk next week.
Thank you much.
All right. Thanks, Pat. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.